Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
And good morning, everyone. Thank you for joining us with PerfWeb was 48, 46?
At 46, Journal
PerfWeb
Club
46,
9.
Journal Club number 9.
Yeah.
So welcome to Tammy Sparacino's Journal Club, and then PerfWeb 46, technically. So, and we do that for our accreditations and so forth. Very quickly, get through my housekeeping notes. We need to thank our sponsors, LivaNova and Siemens Health and Ears. LivaNova, of course, as you well know, is a leader in cardiopulmonary products, and Siemens is they have a wonderful platform. Of course, they do laboratory stuff, but they have a wonderful point-of-care laboratory analyzer that I'm very supportive of. Now, I get paid nothing from these people personally, but they do support our show, and we're very grateful to have them as part of our sponsorship. Also, sponsor HET, Houston Extracorporeal Technologies. Our website there, het.us. If you are looking to move to the Houston area or are in Houston and would like to work for a great group, I highly recommend you give us a call. We are hiring and we are expanding. And I think you would, the website has all of the information I think that is pertinent to the group and something that you can take a look at and make a assessment for yourself whether or not this is the right company for you. Social media pages, please take a look at, like us, follow us, share us on YouTube, Twitter, Facebook, and the LinkedIn, and also click that subscribe button. Our subscribership continues to grow. We are #1. I need to stay #1, and we're going to be #1 by you guys subscribing to our YouTube channel. Very important to us, please. And don't forget to give us that thumbs up, that like, okay? If you'd like to reach out to us, and actually somebody just did reach out to us, well, first let me just tell you the website names. So you have perfweb.us, which is a place where you find our schedule of events. And then you have perfusioneducation.com, which is where you go in order to view our library, become a member. Membership is free, of course. You can view all of our entire library of videos. But we have, obviously, plans for people who need the CEU. So it's free to watch, free to participate, But if you need the CEU certificate, then you can become either a member for an unlimited plan, or you can do the pay-as-you-go cafeteria plan, if you will. So if you need 5 credits, you can get 5 credits. If you need all of your credits, you can become an unlimited member, and that's going to get you all of your credits for your 3 years that you will need. And we're adding more to that library each day, so please take a look at that. But I got an email from, and I'm probably going to butcher this name horribly, but Asanga Krishana Kapila Piasena. So thank you so much for this email, and they're asking that we do a program on oxygenators, on perfusion devices, basically. Oxygenators, hemofilters, tubing, circuits, arterial filters, cannulas, cardioplegia delivery systems. So Asanga, I'm going to be doing, we have a webinar scheduled for the 14th of November, and we are going to have Dr. Badia here, and we're going to be talking about the history of wine as a medicine, and also alcohol. I'm actually going to give a lecture on the history of alcohol as a medicine. Dr. Badia's is more about wine, and we're actually going to also learn how to grade wine, judge wine, how to taste wine, and some other things. So that's going to go on the schedule today for November 14th. It's a Saturday, so please mark your calendars. It's going to be a great show, but I'm going to add to it this stuff for you, Asanga, in the beginning of the program, and do this, a comprehensive review of all perfusion devices. I think that that will help you guys out there. I'm not sure where you're from, but I would love to know. If you could give us a call, maybe another email, and let me know, it would be greatly appreciated, and for you to participate in the program. Okay, what do I go to next? Our app? What about our app?
Phone number.
contact@perfusioneducation.com, and call-in number 832-239-5358 if you would like to be live on the air. Our critical care app for perfusionists is being sold. They're almost going like hotcakes. Fortunately, there is no limit since it's
unlimited.
A virtual. It is truly unlimited, exactly. So we appreciate all of you people using it. Please give us some feedback. Let us know what you would like to see in the next version, so that when we do an update, we will incorporate those things in the update. So, give us 5 stars if you would, and of course, leave a comment so that we can actually make the app even better. But right now, it's a great app. It has a perfusion section, an ECMO section, hemodynamics section, conversion section, medication section for those of you who may be nurses or your wife may be a nurse. There's a smaller version of the app as well for just medications and drip rates. But in the bigger app, which is only $2.99, you get everything in one. And I think it's a very useful tool. In fact, Tammy, who's sitting next to me, who I'll be introducing you to here momentarily, the star of this show, actually has used the app, and I think she likes it very much. So let's just do that. Let's just go right over to Tammy. Welcome, Tammy, to your program, the Tammy Sparacino Journal Club. Your idea, your concept, which I think was fantastic. I love it. I think it's gone so well thus far, and I appreciate it as a suggestion from you, but even appreciate more how much effort you've put into this and how valuable the information's been. I've learned a lot from you. So once again, welcome to the program, and the floor is yours.
Okay. Good morning, everyone. Today we are going to be talking about this article. It was published in the Journal of Cardiac Surgery in May of 2020, and it's Postcardiotomy Extracorporeal Membrane Oxygenator, No Longer a Bridge to Nowhere. It's by Dr. Merritt Ganor out of the University of Nebraska Medical Center, Medical School rather, I think. Yep, both. All right. So here's the abstract, and it's kind of lengthy, but I'll just go over it with you quickly. So the background is postcardiotomy extracorporeal membrane oxygenation, known as PC ECMO, represents a unique subset of critically ill patients with a paucity of data regarding long-term survivability, correlated characteristics, and they are going to, in this article, present a retrospective cohort of patients with outcomes of 1 and 3 years. It was collected from the years 2006 to 2017. There were a total of 246 patients, ECMO patients for them. 31 of them were considered postcardiotomy ECMO. The average age was 66 years old, and 71% were male. Let's see, they had 4 transfers to their facility. Most of the procedures were elective, some emergent, and a few were considered true emergencies. All right, so the reason this paper was published is, as anyone who's been in the field a little bit knows, that ECMO has become more popular, especially with adults. Since 1990, there were, according to, I believe this is quoted from ELSO, 1,644 ECMOs run at 83 centers. And then going all the way up to 2018, 10,423 cases among 391 centers. So you can see there is definitely a growing use for this type of therapy. And this particular syndrome of why these kinds of patients need ECMO support is very severe and has a very low survivability compared to overall ECMO as a bridge for recovery.
Let's say maybe instead of an MI versus cardiogenic cardiogenic shock survival versus where you've been in the operating room cross claims. You're saying that survival comparatively is very low.
Right, and there's not a lot of data on it because it does occur infrequently, but frequently enough that we want to try to understand it a little bit more. Mm-hmm. So they took this study, and it's actually very comprehensive with the data points, although their sample size is on the smaller side with 31 people, but they have so many data points that they compared, really too much to go into for just our quick review of this, but it's a worthwhile article. So let's, the significance of it is they wanted to see survivability at 1 year and 3 year for these types of patients, okay? Okay, so the problems to be solved is they looked at a lot of actual data points, but a couple of the things that came out that I thought were interesting. Most common problems, limb ischemia and CVAs. And then they had some unique subsets that they looked at. Quite a few of the patients qualified for frozen mediastinum. They looked at immediate versus delayed ECMO support. They, for the most part, 87% were VA ECMOs, but they did have 13%, which I think amounted to about 4 or 5 patients that were an RVAD with an oxygenator configuration, and they went ahead and included those as well. They looked at central cannulation, which was around 83%, and versus peripheral, which was about 14%. Mm-hmm. For patients to be included, that they needed to go on ECMO within 72 hours of their initial surgery, no transplants, and no LVAD patients were included. Let's see, what else do I have for you here? Okay, let's get to their results. Oh, I kind of went over the how then as well. All right, so let's get to conclusions. So their data was actually pretty interesting because it didn't show any correlation with survival and factors that had previously been thought to contribute to mortality. The STS-PROM, the case status, elective versus not, age, sex, BMI, type of operation, the operative times, including the cross-clamp time and the total bypass times, whether or not they had an open chest, if they had a reoperation for bleeding. All of those things in other articles that we're going to discuss a little bit later when we get into our big topic have been shown in larger studies to correlate with survivability. Their data showed that patients who were centrally cannulated tend to have a trend towards improved short-term and long-term survivability for this type of support. And I thought this was a great consideration that they said. They think that perhaps that had to do with better venous drainage and cardiac offloading, because at their facility at the time that the data was collected, an LV vent was not something that they was a part of their practice to put in, you know, whether it be an impeller or whatever. Let's see.
Can I bother you one
Oh
second?
yeah. Yeah, I have that written down somewhere. Hold on, let's go back. Joe wants me to.
Yeah, if you could,
Yeah.
I don't mean to interrupt you, but I had never heard the term for, I'm assuming, adhesions from a redo. I've never heard the term frozen mediastinum. Have you?
No, I had to actually look that up, and so it basically is when you have a redo mediastinum or a chest that has radiation.
Okay. Yeah.
So both of those qualify, and I think the reason they bring that up is, of course, those are going to have adhesions. It's going to take longer to get in and to close up, and so therefore you're going to have longer bypass times. And they found
And operative. Well, do you have longer bypass times or operative times?
Oh, sorry, I misspoke. Operative times, and with those longer operative times, they found, I believe, that those patients required a few more units of blood versus the ones who were not, as they call it, frozen mediastinum. So because they collected so much data, it was very comprehensive, and they looked at a lot of different things. And so it sounds like they had several patients that were redo chest, and I believe one radiation, and so they took that into account when they were looking at those sorts of things. And in fact,
And I had one more question for you, if I could.
Yeah.
But I just wanted to give you this note real quick,
Yeah.
just to make sure we cover that as well.
Yes.
But one more question I had for you is, what does, because I mean, there's maybe some people watching this just don't know, what is the STS PROM score?
Yeah, I have to let me read that right there. So it's the predicted risk of mortality, but they actually give a very nice explanation in here that I should have actually highlighted. Of course, I'm not going to be able to find it now. But
Well, they have a risk calculator, right?
right, and that's actually a good point to bring up, because as we get into our talk later, I'm going to talk about another predictive calculator that helps you determine survivability and mortality for for ECMO and this type of support.
Okay, so for specifically a risk calculator for ECMO for postcardiotomy syndrome.
Yes.
So specifically for this issue.
Right. So I think most people are probably familiar that STS does a scoring system so that you're able to look at the overall risk of mortality for cases, and sometimes cases may be turned down because the STS score is considered too high.
I've seen it happen.
Yeah, definitely have seen it happen. So that's something to keep in mind, and so they did consider those scores within this particular study. And another article that we're going to get into later that goes along nicely with this article, that's just a little bit more comprehensive, has a different predictive score, which I think is really interesting as well.
I'm looking forward to that. Did we put this article's title up? I don't remember.
Yeah, sure.
Let me make sure that it's up there so anybody that wants to see this can go get this article. Okay, there we go. So, all right.
Yeah, so this is the name of the article, definitely a worthwhile read. It's written in a very clear and concise manner, and they have more tables comparing just about any type of data that they could collect from these patients. They did.
And this comes from, you said, from Nebraska, from University of Nebraska?
Yes, University of Nebraska.
So isn't there a big perfusion training program there, Northwestern?
Yes. No, it's at
Midwestern.
It's at University of Nebraska, and they do an undergraduate degree in perfusion, if I'm not mistaken.
Okay, very good.
And then they also have a graduate degree program for perfusion as well. But this one in particular is out of the medical school that is there.
Excellent. Okay,
Yeah.
Thank you.
Sure. All right, let's just click back ahead here a little bit. And so we were just summarizing their conclusions, and they did note that the central cannulation, they had a higher trend towards improved short-term and long-term survivability, and they thought that was due to perhaps to venous drainage and cardiac offloading, just because the cannulation, you know, is better on those sorts of things. And they thought that this, because they didn't use LV vents at the time of their collecting this data for these cases, because this is a retrospective study, they thought that that would be an area for further emerging studies to look at if that did play a part. Okay, and I loved this. So they actually put into their discussion what their procedures are there of when they're going to consider postcardiotomy support, and it's summarized really nicely. So it's, you know, if the inotropic support has escalated above moderate doses, a period of rest does not improve the cardiac function, and they we're talking about rest when you're on pump and you're just kind of letting the heart rest to see if it can become more, could gain more contractibility.
Yeah, beating empty with good perfusion flow to the coronaries.
Exactly. And I liked this, that they were so specific that they do the period of rest until the team feels the patient will be safe overnight without mechanical support. Now, during that period of rest, if the patient is maintained on cardiopulmonary bypass, you're also going to optimize any potential deficits that might be contributing to the myocardial stunning. Your electrolytes are replaced, your ventilation's adjusted, ultrafiltration is considered.
And I think that should be absolutely mandatory.
Yeah.
I think that for some reason, there is a political reason that people are so afraid to say, give albumin, give hypertonic, and get the
extra fluid,
tissue edema
right,
reduced as much as possible. Because every time I've seen one of these hearts trying to come off pump where we have postcardiotomy syndrome and we're not coming off pump, every one of them looks swollen.
Yes.
We've seen it. How many times?
Yeah. Consider an IABP and employ it if necessary. And then a reasonable amount of time for resting, generally 30 plus minutes. So they really have a plan there of how they're going to handle these things. And I thought this was nice for anyone who is looking for just a basic outline of the kind of things that you can consider to try to go ahead and get that patient off pump. Now, if all of those things fail, the heart is not improved, the inotropic support is still required at very high doses, then they consider resting the heart. Will have to continue temporarily with ECMO support. So that's how they handle that in their facility. Okay, so we kind of did a panel discussion as we went, but do you have some more specific questions or anything specifically about this article before we get into our big topic of the day?
About this specific article, no, not really. I think that it's a good segue into what is this topic, because I do think this topic raises its ugly head now and again. You can't do heart surgery, and it's usually the ones you least expect to have it happen to. And it's like, you know, we anticipate it's going to happen in this case, and we do all of these, you know, various machinations, and the patient comes off pump.
Yeah, we do a lot of
well.
like proactive, preemptive type of work, and then
yeah, no problem. And then the other ones, it's like, this is a chip shot. Every time you say that, you know, it's like, don't say it, because double vessel, easy, simple coronary.
Right.
And the next thing you know, you can't come off pump for some reason.
Yeah.
So anyway, with that said, I will let you proceed. And John Ingram sent, in compliment to what you just said, Joe, in nearly all of these cases, the chest cannot be closed, and this is due to myocardial edema. Exactly.
yes, exactly.
Exactly, John. I mean, I agree with you. Thanks. I'm glad you're watching the show. We miss you.
Yeah, John couldn't join us today. He had to end up doing a case, as we all know.
He's working.
Yeah, gotta work.
About time.
All right, let's get into our perf web portion and our topic. Postcardiotomy, cardiogenic shock, and VA ECMO. Let's get into this just a little bit more detail. First off, let's just talk about what is cardiogenic shock. I mean, I think we all have a general idea, but here's what I found in the Journal of American Heart Association that was published. It was kind of a up-to-date review of cardiogenic shock, and it's caused by severe impairment of the myocardial performance. Well, you'll have diminished cardiac output, end organ hyperperfusion, hypoxemia. The clinical presentation will be hypertension, refractory to volume resuscitation. It's going to have features of end organ hypoperfusion requiring pharmacological or mechanical intervention. Okay? Now that we understand just in general what is cardiogenic shock, here's some of the most important trials and studies that have been done in this subject matter. You'll hear a lot of the shock trial, and it actually has a clever name. It's what is it? It's escaping me right now.
That's okay, go ahead, I'll look it up.
Yeah, it's clever, and I really liked it. So you can see, the reason why I put this up there is because there are lots of really important trials, 5 in particular that I found that are quoted a lot. But they all have a little bit of different ways that they look at it, different ways that they define what is cardiogenic shock. And most of them are going to say, you have suppressed blood pressure. The numbers can be less than 90, less than 80. They're in that particular range. One in particular called the IBP study that was done in 2012 is less than 70. But they look at various things on how they're defining it. How much myocardial stunning do you need to actually qualify for that?
Mm-hmm.
Do you have the shock?
I do.
I love it.
Should we emergently revascularize occluded coronaries for cardiogenic shock?
Yes.
That's the shock trial.
I love it. It's like long and fun.
Very, very.
Okay.
I'm glad they called it the shock trial.
I know. That's why I couldn't remember. I know that there's extra words before you get to the H, and I was trying to remember what they were. Mm-hmm. Okay, so in addition, in that same article, they also talk about the mechanical circulatory support device evidence, and there's one, it shows you all the different trials that have been done and what they actually looked at. So, for example, the IBP shock 2 trial looked at IBP versus I'm tongue-tied, versus the
Impella?
No, hold on. Don't say anything. I'm just tongue-tied. Let me just read my notes here. Versus, I can't see it for some reason. Optimal medical therapy. So just versus, using drugs.
Copy.
What those looked like. Then we've got the shock trial, which looked at the cardiac power. In other words, devices and how much more power they give the cardiac, but with their support, and so on and so forth. And so you can see there's a lot of different things that you can look at when you're trying to assess cardiogenic shock. Okay, let's move on to this article. Now this is a little bit older article, but the main article that I found a lot of information and data that we're going to talk about today refers to this article quite a bit. It was a comprehensive article done in 2018, and it looked at risk for mortality for ECMO for this particular type of shock. It was done by Dr. Fuchs, I believe is the name. I hope I'm not pronouncing that incorrectly.
I would say Fuchs.
Fuchs.
Let's try that.
Let's try that. All right. I don't know.
Welcome to the show.
Good morning. Okay, postcardiotomy, cardiogenic shock is often abbreviated PCS. And in this article, it's defined as low cardiac output syndrome. You have evidence of hypoperfusion, end organ dysfunction despite adequate preload. It affects 0.2 to 6% of patients who undergo any cardiothoracic surgery. They define it as a life-threatening complication with mortality rates between 50 and 80%. It's an inability to wean from cardiopulmonary bypass or deterioration of myocardial function during the first postoperative days. They say of those patients, 70 to 90% of the patients who cannot be easily separated from the bypass machine because of PCS will be able to be weaned using inotropics, vasopressors, and an IABP. So the majority of the patients that you're going to have trouble weaning, you're probably going to be able to do these other things versus having to move on to ECMO mechanical support. Estimated 2/3 of those patients will recover hemodynamically without the need for anything else. Now, the ones that don't, then you get what's called refractory postcardiotomy cardiogenic shock, or abbreviated RPCS. It occurs in 0.5 to 1.5% of those patients, and they will need additional mechanical support or they're going to die. That's just basically what it comes down to. So the VA ECMO support for this RPCS is partial or complete cardiopulmonary support. It can be a bridge to myocardial recovery. It can be a bridge to heart transplantation, a bridge to a long-term VAD device, or a bridge to other interventions. Okay, so let's get on to this next article, which this one was published in May 2020 in the Journal of Thoracic and Cardiovascular Surgery. And it was a study done over in Europe that looked at...
Looks Italian.
Yeah, it is done in a... it covers centers in a lot of different countries.
Multi-center.
Yeah, multi-center.
Oh, yeah.
And it's done by... But when they say multi-center, they were really comprehensive. And since I'm not doing well with names today, why don't you go with Dr. Biancari? I don't know.
Biancari.
Oh, that sounds better. Yeah, let's go with that. He was head up on this study. So the objective of this study was to look at risk factors associated with early mortality for the postcardiotomy VA ECMO. And they did an analysis of, let's see, 781 patients that were all over 18 years old, and they required VA ECMO for cardiopulmonary failure after cardiac surgery. The years they looked at were 2010 to 2018, and they included 19 cardiac centers.
Wow.
It's very comprehensive.
Impressive.
Yeah. Okay, so they have a bunch of, here's all the centers, just so you can see. They went with centers that do a lot of heart surgery. You can see on the first column, it's just telling you where the center was located. Second column, how many cardiac surgeries they do during that period. You can see some of them are, you know, tens of thousands there. And then how many of, by percentage and total number that required the VA ECMO for postcardiotomy syndrome. And you can see quite a few of them have some bigger numbers there.
I'm telling you what, Dusseldorf, I don't know how you pronounce that, Rennes, Hamburg,
Yep.
Glasgow. I'm surprised at that many in Glasgow.
You
frankly.
can see that the percentages themselves are within, for most of them, in predicted range of what we had just seen in the previous study, but they do have quite a bit of case numbers for just overall experience.
Absolutely.
Which is going to come into play with some of the things that they determined. Okay, so here's what this article has to say about it. So VA ECMO for PCS, the early experience with this, about 25% of the patients survived a discharge, and 17% of the patients survived to 1 year. Now, through the years with continued use, there was marked improvement. Up to 36.1% of the patients survived a discharge, and almost 31% of patients survived to 1 year. Looking at this table, these are the main causes of death in patients who died on VA ECMO for this type of support. Multi-organ failure was at 20%, heart failure 13%, neurologic complications 5%, and so on and so forth. It goes all the way down to even a transfusion reaction, okay, which was a very low percent. They only had one, but still, they looked at a lot of really everything that you could attribute to a death on VA ECMO. Okay. All right. So this table had a looked at the kind of the operative data, and I've highlighted, they looked at many data points, but I've just highlighted the things that they found statistically significant. And you can see that the aortic arch surgery was found to be statistically significant. Oh, first, let me talk about the categories. So first one is just the data point that they're looking at. The second column is the overall procedures of, or rather patients. The third one is the ones that survived. Fourth are the ones that died, and then all the way to the right is the p-value, so how we determine if it was significant. So aortic arch surgery was found to be a significant factor, okay? And then cannulation. So the type of arterial cannulation, not specific to one type, but just generally speaking, arterial cannulation was found to be statistically significant. Let's see, aortic cross clamp, and then bypass time. So these are some of the things that our first study, and maybe again because they had such a small sample size, did not see correlation with these types of things.
Yeah, because I would think just intuitively that cross clamp time and cardioplegia time or pump time both are. I mean, I think we recognize them as independent predictors.
Sure, sure. And this study it has referenced a lot of other studies that have been done over the years. It's very comprehensive, and so I do think this, and with such a large patient size, I think it probably is pretty representative of what's out in the literature today.
You mean such a high N number? You're saying?
Yes, exactly.
Sample size.
It's a very high sample size. Okay, so then this one looks at just the data that was while on ECMO, and you can see that they found a few things statistically significant. There's arterial cannulation, venous cannulation, the
lactate level.
Lactate level. Yes. Okay, so that's something that they really talked a lot about. Was higher lactate levels was an independent predictor for death on VA ECMO.
Yeah, you just have such a deficit.
Yeah, you just can't catch up.
Out. Yeah, absolutely. I've seen that happen before as well.
Yeah. Okay, and then this one, that chart was so long that I had to continue it. So it's the same table, the bottom half. And this one also found several things, significant, everything in heart transplantation. It was very significant. What else? Yeah, let's move on to this one. Okay, so.
And how long they were on VA ECMO.
Oh, yeah, and overall duration, sorry. Yeah, of course, overall duration. And you can see that it's less than 0.001, so incredibly significant. All right, and then this one looks at, I don't know why I can't see today. I need my glasses.
Do you want to switch seats?
No, let me just look that way. I forgot my glasses,
Here.
so I'm struggling just a little bit.
So
these are, yeah, it's good. These are the outcomes that for the patients that underwent the postcardiotomy VA ECMO support, and the length of stay in the intensive care, whether or not they were trached, liver failure. Let's see, what else? There was another one. No, and renal replacement. That's what I wanted to get to, which John, I was hoping would be here to talk about that. That one is incredibly significant. Okay, so here's what I really wanted to get to.
Do you want my glasses?
Nope, I'm good now.
Okay.
Those are just my tiny charts, and I forgot my glasses. So sorry about that. All right. In this article, they talked about postcardiotomy ECMO score. And so just like STS has its own criteria for scoring patients and their mortality, and the predicted mortality, this one too is hopefully can be used preoperative to predict whether or not the mortality of the ECMO of the patient for this type of VA ECMO.
So this is that thing you talked about.
Yes.
This is the postcardiotomy ECMO support survival score.
Yes, it's supposed to be a predictive tool to be able to stratify the risk of mortality after VA ECMO support for PCS. Okay.
Okay.
It's
after the initiation of ECMO support.
Right.
Or before ECMO support.
You're looking at it before ECMO support to
Okay.
decide if these patients are going to survive.
Okay.
With the is it worth it to
So
put them
you're
on ECMO?
You're on pump. You're not coming off. You've tried everything you know to try.
Yeah.
You've now made the decision we need to go to ECMO, and so then this particular methodology comes into play.
Yes.
So let's do this. Let's go over that. I want
Yeah.
to go over that slowly.
And it's actually pretty simple, which is great because I'm not a statistician. I don't know how to necessarily do those things. I haven't had statistics class in a really long time. This one's basic, and I think everybody can understand it and be able to apply it. So it's just derived by assigning a weighted integer to each independent factor for pre-VA ECMO for hospital mortality.
Okay.
If you're female gender, it's a 1 point. If you're advanced age with 60 to 69, 2 points. If you're older than that, 70 and older, it's 4 points. If you've had prior cardiac surgery, it's 1 point. If you have a lactate of 6.0 or greater just before going on ECMO, okay, that hasn't been resolved and it's before going on ECMO,
Absolutely.
2 points. If it's aortic arch surgery, 4 points. And if you've had a preoperative stroke, unconsciousness, CPR kind of thing, 5 points.
Well, yeah, I mean, that makes a lot of sense. And I'm not surprised because, how many times we're trying to come off pump, we've got this refractory acidemia going on, we can't clear it, given bicarb and so forth. I think all of us just sort of assume it's dead gut. Dead gut, you're not going to make it. Once you've been pouring in all those pressors.
Well,
Bad hypoperfusion, all those pressors, all that. But go ahead. Let me do yours. Go ahead.
Well, before I lose my train of thought on that, and even once you're on ECMO for any other reason, if you're seeing that lactate climb and nothing's being done about it, we're going to get to the point of no return, and we're not going to be able to get them back.
Yeah, and you can treat the elevated lactate, but you have to treat the underlying cause first.
Right. You can treat the lactate, but if you can't figure out what's causing the lactate,
we have all kind of tools to clear lactate. Flow is the best one, of course, but if it's unresolving and needing a bicarb drip or needing continuous renal replacement therapy in order to clear the lactate, and the lactate continues to climb, every time you try to stop those things, you have to fix the underlying problem. I think sometimes that gets lost in that's like missing the forest through the trees.
Right. But I thought that this, just breaking it down like this, could be really useful. And I don't think any of those things are necessarily surprising. But these are the things that they found were independent predictors and therefore, significant to survivability.
Okay.
So the conclusions of this article, which again, I'm going to put the title up again when I'm done with this, just so you can write it down. It's a worthwhile read. It was multi-center, very large multi-center. They looked at PCS with VA ECMO support. They have saw that there's an increased participation across centers without any real incremental hospital mortality. Center experience with the postcardiotomy might have contributed to these improved results. So the more you do them, the more you know how to manage them, the better outcomes you have. Advanced age, being female, previous surgery for cardiac reasons, preoperative, CVAs, aortic arch surgery, increased arterial lactate were all associated with increased risk of early mortality. The risk factors they think may be a good guide for decision-making process as to whether or not to initiate this. So that's another thing. We could have a they talk about this, puts you in an ethical conundrum, if you will. if you're putting people on ECMO without really thinking about whether or not they're going to be able to survive it. And we see that in all types of, ECMO support. But in particular, they were looking at that there aren't a lot of guidelines as to determine when is ECMO a viable and ethically responsible option for these types of patients.
Yeah, that is man, I'll tell you what, that's such a great conversation. We'll have that a little bit because that is actually, you bring up a very good point. But
and I'm going to go back to the article title.
Well, before you do that, can you go back?
Sure.
Well, how do you score this?
Okay.
You add them all up, but what does all of that mean? I feel cheated.
Okay.
I got all these points, but I don't know what to do with them.
I'll leave you this article. It's not as simple of just adding them up. Hold on. It's a little bit statistical, but you can already see higher scores are going to. Let me find their particular data table on scoring. And okay, so it gets into, it's one of their last tables. And the only reason why I didn't put it up is because it gets a little too statistical for me, and I don't want to appear to know how to talk about logistic regression when I really don't. But you look at, they have a table that talks about age, gender, cardiac surgery, all the things that we were talking about, and they have the odds ratio of how often this is going to occur. They use 95% confidence intervals, which is considered a good standard, and it will tell you, just for an example, let's look at one of the higher ones.
Can I give you one?
Yeah.
Can I give you one? Can you calculate it if I give you a patient?
I cannot. Well, because we'd have to know how many of those patients, from the way I understand the way logistic regression, you have to take your variables and then you have to have your total amount of patients and then the ones that had those, and then calculate the survivability from those, and then you get your odds ratio of the percent of those people who had these particular variables and how they survived. So it's a little bit more complex than that.
So we need to add this to our app.
Yes. Yes, we do.
Revision 1 will be
logistic regression.
This. I don't know how to do it, but we're going to put it in there. Okay, we're going to figure it out. Where's magic?
I actually watched a few YouTube videos trying to see if I would be able to explain this. And actually, the first video, I was like, oh, this is good. And then he said, and the next 12 videos we'll get into. And I was like, oh.
Oh, okay.
Okay.
So it's a simple thing, but it really isn't a simple thing.
It's not a simple thing to be able to get, well, it probably is simple.
Because you have to have enough patients that you've had that same experience with.
Correct. But I think what lay people, non-statisticians, or people who maybe don't necessarily have a lot of these cases to look at, can infer that obviously the more points you get, the more of a predicting factor it might be. And so someone who has who had a previous stroke or was unconscious in CPR, it's worth 5 points. So that's going to play a higher impact on their mortality, their mortality, hospital mortality.
So if you're female, over the age of 70, and a redo, with a lactate level greater than 6 millimoles per liter, and you've just had an ascending aortic valve, ascending aorta replacement with say the island, the arch island put on, and a coronary with Lima and say 4-vessel coronary, and you had a stroke beforehand,
you're in trouble.
Probably a poor choice.
You're in trouble.
Okay.
Yeah.
But that's where my next question is going to come in. But I'm going to wait till you're done.
But what do you do?
So no, we're going to let you go. Let's let you go. Then I'm going to start firing off the difficult questions.
Okay. So I'm actually done. That's the end. But I wanted to show the article title one more time, and there were multiple tables and figures that are much more complex than this. And if that's your sort of thing, oops, not there. Let's see. went back a little too far
The
there.
first article or
No,
the second article?
No, it's the third article, actually.
The third article.
Yeah. If that's your thing, then you should definitely. Oh wait, hold on.
You want to just hit the, let them just
There it
find
is.
it? Oh, there it is.
There it is. This is definitely worth a good read, and you might be able to.
Fausto Biancari.
Yep.
Yeah, like a Polish name.
Is that what it's like?
Yeah. Magic. We found our first revision for our app. Something we need to add. I'll show it to you. It's
Don't
going to
look-
be complex, but it's going to be good. We need it.
We're going to make a statistics app. Doesn't that sound fun? Okay, you can take the slides down. Thanks, guys. All right,
Okay,
so that's
excellent.
it.
Well, excellent. I think excellent review of some stuff, and I think our audience really appreciates having some. Yeah, because you can. You know, we're like, hate to say it, but we're sort of filtering out all of the articles and finding the ones that, you know, for you that we think are the best ones for you to read to actually understand this stuff and learn something. So, you know, appreciate your effort, because I know how much time and effort goes into this. And of course, if we had an unlimited amount of time, which we don't, you could figure all that out.
Sure.
You could explain it, but, you know, at the end of the day, it's impossible to do. Plus, God, I wouldn't do the statistics. I mean, that's not something that I would try to tackle either.
It's
I
not my
totally
strong
understand
suit.
that.
But I think that the thing is, too, there are a lot of people out there who that is very valuable information to them, the statistical data, and they get it and they understand and they can apply it to their practice.
Yeah.
And then there's the everyday Joe who maybe wants to understand this particular topic a little bit more and how they can apply it. But like you said, we don't have unlimited amount of time to go research this.
Notwithstanding the score and all of the various different fancy formulations you have to do to actually come up with a percent risk of mortality or survival, either one. David, would it be possible for you to put that last slide, but would it be too much of a hassle? No. The last slide.
It's the
second to last slide.
third to last slide.
Third to the last slide.
I think it
whichever
says
is.
PCS ECMO predictive score.
That's it
Yeah,
right there.
Yeah.
So yeah, throw that up. So what I take from this, notwithstanding not necessarily having a this calculation completely done, even though I think we're going to try to do this, and we really are. I'm going to try to put this as a revision in our app.
Okay.
I think it's a very important thing to have. But what I take from it is that when you can't come off pump, there are some things you need to be considering.
Correct.
Is the patient male or female? How old is this patient?
Yes.
Has this patient had prior surgery? And the big ones are, is my lactate level, really high? So advanced age over 70, big points. Arterial lactate levels high, another, important. Arch surgery, important. And whether they've had a previous stroke or were obtundant at the time of their, operation to start with.
Yes, that's what they're talking
And
about.
so, and when I say pre-op stroke, they mean at that, I'm assuming they mean in the immediate preoperative
Right, that
phase.
led up to that particular
Right, not
surgery.
a previous stroke from
Correct.
5 years ago.
Correct.
Or a remote stroke.
Correct.
So I think those are, it really gives you the basically the headers in which to start taking into consideration these things before we move forward with this next thing. Because a lot of times in these situations, thanks, you can take the slides out. A lot of times in these situations, what I have found, in my experience anyway, is judgment gets very clouded.
Mm-hmm. You're only seeing that you can't get off pump. What's the next step?
Yes. And
Agreed.
not taking all of this into consideration.
Well, and
I've seen that happen a number of times.
That's another reason why, that line of thinking is exactly why in the first article, our actual article from the review that was out of University of Nebraska Medical School, when they talk about just their plan, that they have a plan, that they already know, okay, I'm having trouble come off pump. These are the things I'm going to do first. Because like we, I went over the percentages then too from, and how did we decide we were going to say this so that I'm not?
Fuchs.
Fuchs?
I would say Fuchs.
We're going with Fuchs.
That may not be correct, but it just sounds a little better.
It sounds a little clearer that I'm not saying something I shouldn't say.
Yes, correct.
Okay.
Online, because YouTube will filter it.
Yeah. I'm not saying a bad word. I
Yes.
think it's Dr. Fuchs.
It'll work.
Okay.
It works.
Anyway, when he talked about that, you're going to have patients that don't immediately want to wean from bypass. But there are things that you can do, and most of those patients will end up coming off without mechanical support. And then the team over at University of Nebraska, they then told us it's very simple things to start thinking about. Do you need to adjust your ventilation? Do you need a little bit of inotropes? Do you need to take off some volume with ultrafiltration? Do you need to rest?
And it's not just not just taking intravascular volume off.
Right.
I want to hammer on that
Right.
today.
It's not clearing your reservoir so that you don't have much volume in there.
Yes.
Right. Right.
I don't know if it's ever happened to you. I'm going to ask if it's happened to you. If it's happened to anybody out there, let me know, okay? But it's happened to me multiple times to the point that, understanding plasma refill rate or PRR is very easy for me to understand now. I'll give some albumin. I'll start ultrafiltrating. Let's say I just have a full tank. Patient was just massively fluid overloaded. And as my reservoir level starts to come down from the ultrafiltration, and let's say I've got 3,000 in it, just for the sake of the argument, I get down to 1,000. I'm not giving any more volume.
Yeah.
But the volume keeps coming.
Mm-hmm.
It keeps coming. It keeps coming. I have taken 6 and 8 liters off of patients that got no additional volume from me at all.
Mm-hmm.
Simply by raising their COP, not to some supranormal level, just to a normal level.
Just giving some albumin.
Some albumin, and then when you start ultrafiltrating, getting the plasma water off, it concentrates it.
Mm-hmm.
Your crit goes up.
Yep.
Your protein level goes up, and of course the result of that is a pulling effect out of the interstitial space back into the vascular space where you can remove it.
Mm-hmm.
And I've heard people say, well, you're going to put them into renal failure, and I don't really understand why they believe that. It just simply makes no sense. They say it and they believe it, but they certainly can't explain to me how or why, because if I'm making their physiology normal and I'm reducing the edema of the heart, the lungs, the liver, the kidneys, and the kidneys are actually now being perfused where they weren't before,
Mm-hmm.
how can being total body fluid overloaded affect you in a positive way? How can having 10 liters more volume in your tissue make you pee more? If it's not in the intravascular space,
it's not there.
It's not going to happen.
Well,
but you have perfusion deficits because the microcirculation, you have compartment syndrome in every single end organ.
When I first graduated and was out doing, ultrafiltration, I just remember that it was just, you want to make sure that you had a higher oncotic pressure for your prime so that you're transferring that over to the patient. You're then going to take off the volume that you can and also monitor urine.
Mm-hmm.
So if you still have urine, while you're on bypass and you're doing these things, you can't possibly be doing harm to the kidneys. I don't understand that. And to your point, you're not just taking off the volume that is, in the vasculature.
Mm-hmm.
The whole point is you're taking off the extra volume that is in the tissues.
Yes.
Right?
Exactly. Because again, if you have massive fluid overload and you have significant tissue edema, then it stands to reason the microcirculation is going to be grossly compromised. And again, you have these long pump times, You see these very high lactate levels. Well, where do you think that's coming from? It's coming from ischemia.
Yeah.
It's coming ischemia somewhere, and generally the gut. The gut is extremely sensitive, and I have seen, I'm sure you have too. I have seen intestines that were just so edematous and swollen, and you just can't perfuse them, and you end up with dead gut. And once you have dead gut, you're done.
You're done.
You're toast. It ain't going to come back.
No.
We can't fix that. So you need to avoid that. I think avoiding fluid overload is so critically important. But we get a lot of our patients already fluid overloaded. But they'll do an echo, they'll look at the heart, and they'll look at the chamber size, and they'll say, this patient is euvolemic. Well, they may be euvolemic or hypovolemic even intravascularly.
Right.
That doesn't mean they are hypovolemic in total body fluid volume.
Don't you think some of the pushback for using ultrafiltration comes from people, doctors specifically, because of course that's who we work under the direction of, who are thinking that when you're ultrafiltrating, that you're taking off all the circulating volume, so then the patient's going to be dry, and so then they have elevated hematocrits, but they're not, they're going to end up looking better than what they actually are, and they're going to have to end up giving volume or something once you get them out of the operating room. That's what I have been told. That's the pushback.
I've been told that too, and my response to that is, okay, look, if we're measuring CVP, if we're measuring PAD, if we're measuring systolic and pulse pressure variation under mechanical ventilation, which we are, if we're measuring SVR, and all of those are normalized, and the heart is full and beating well optimally, even if the off chance you pulled a little too much, made them a little bit too dry, and you end up, they end up having to sort of, equilibrate over time, and maybe they need some volume in the ICU or whatever it is in order to compensate for some fluid getting back into the tissue. So what? I can tell you this much. When you close that patient up and you get that patient to the ICU, it is a lot easier to treat your underlying, hemodynamics, CVP, PAD, SVR, etc., with fluid administration, much easier to give fluid than it is to manage a patient who has now low cardiac output syndrome. You're giving them all kinds of pressures. You're giving them inotropes. You're giving them, big doses of Lasix. And you're struggling with a patient who basically has microcirculatory perfusion deficits on a global scale. To me, much easier to do that in the operating room on pump and come off optimized than it is to try to do that in the ICU with a fluid overloaded patient. Makes no sense to me.
Well, and I'll even make it even simpler. We're adding volume with the prime and the cardioplegia and those things at minimum.
And anesthesia.
Yeah. Let's say you have the best anesthesia in the world, and they're not adding any fluid back there.
None.
Next to none,
Okay, let's give them 2 liters in reality. Come on.
At minimum, you should be trying to take off that particular volume that you have introduced into the patient anyway.
I mean, if you use Del Nido with the pump prime Del Nido, even if you wrap, which I think is the worst thing in the world to do. I'm just going to tell you all. I'm just going to tell you right now. I'm just going to say it one final time. I'm only going to say it one final time. I think the wrap procedure should be condemned and never used. I think it should be a class 1A will do harm. That's it. I don't think it's a 1A. What's the one that does harm? A class 1C.
Yeah.
1C.
C.
Yeah, class 1C.
Yeah, A is
it
good.
Does good.
B is don't know.
C is,
I
1C.
think
That's what I think. And I think this hemoconcentration thing, this is my humble opinion, because I'm very humble. I do believe it has become a political football. That's what I think. It's become political over this. There are some people that are just so deeply entrenched with We shouldn't be doing this for some inexplicable reason. There is no data.
All right. I think
No
we're gonna have
good
I think
data.
we're going to have a topic on this one.
Yeah, no good data that says hemoconcentration hurts anyone. It's a ridiculous argument. I mean, I think it, and sure, I'm happy to discuss that. Glad to hear you. Let's see. Karen, how are you? I joined a little late. Sometimes it happens that my reservoir volume is in the pleural space. Yes, absolutely. Absolutely. And good morning to you, by the way, Karen. Good to see you again.
While you're responding to her,
Yeah.
so just bring it back to where we hit before we got off on our ultrafiltration passions. These articles, the first article I discovered, and I loved it because it was don't always find articles that are here in the U.S. where you know, a school that has a perfusion program, and so I thought, oh, this is going to be a worthwhile read, and it really was. And then, you know, it led you down a rabbit hole where I had to know more about this. And these other two articles are definitely can bring you up to speed on what's going on with PCS techniques for you to consider when you're trying to manage your patients that you can't get off bypass. And then when those don't work, what to do if, are you going to do ECMO? Is it worth doing ECMO? And what you can expect your mortality rates to be.
I think you can I agree with you 100%. I think you can avoid a lot of postcardiotomy shock need for ECMO simply by optimizing the patient before you put the patient on ECMO. I mean, I have seen it over and over again. You take these patients to the ICU and they look like they are water balloons. I've seen it over and over again.
Not just hurry up and get off pump. Let's make sure, is the patient ready to get off pump? Have we done all the things that we need to do? Because if we do, what was the number? 60 to 70% are going to be able to, with some adjustments, be able to come off pump and recover hemodynamically.
Yes, absolutely. And it was still a very high percentage of patients who actually left the hospital on top of it.
Yes.
Alive.
Yes, absolutely.
And went on to living. And I think some of that selection, obviously.
Of course.
I've got some tough questions, though, that I need to get to. And
all
this
right,
is a tough one, all right? So I've got two really tough questions. First one is, how do you address places that have nothing?
No ECMO support.
They have no ECMO, they have no Impella, they have a balloon pump, that's all they have. What do you tell people out there that may be watching the show currently or may watch this video later? What do you tell them they need to do? How do you address it? Because there are places, I know places that have neither. Still to this day, they're doing heart surgery, and the only thing they have is the pump that the patient is on, and I've seen them keep those patients on that pump. Okay, and of course that is really a very suboptimal methodology because you don't want a reservoir when you're trying to go to the ICU. I've seen it happen before where they're rolling down the hallway on the pump and the reservoir volume, because there was a hill up or down, and I mean, I've seen it. I mean, and it's frightening. But there are places, believe it or not, still in this country, the United States of America, and probably many in Europe and probably many in other parts of the world as well, who do heart surgery with no ECMO capability whatsoever, nor something else like Impella. Of course, Impella is not going to help you. You have to have an Impella. You have to, if you have biventricular failure, it's really not going to help you that much.
But it could help you in some of the, you know, it could, just like an IBP, you know, it could help you in some of these instances where they do respond to some of the preemptive
unless
treatments.
it's the right side, and then you have to have have to have the Impella right side. But I've got a second question for you. What do you tell those people first? Let's let you do that.
Well,
you got to tell them something. I just tossed the grenade your way.
You have to make sure you're managing and optimizing all the tools that you have prior to getting to the point where you aren't going to be able to come off pump. And sure, there's going to be some that perhaps are unavoidable. Their hearts are stunned, and you've done all the things you can do. It is a lower percentage, so for this particular syndrome, so you do have that working for you. But I think, you know, the plan that University of Nebraska doctors gave us. You're going to optimize the inotropes. You're going to make sure the ventilation's correct. You're going to remove extra volume. You're going to rest the heart. If that means you need to, surgeon needs to take a break for a bit and you rest on the heart, warm, just resting, letting the pump do the work for 30, 40 minutes, whatever, then you do that. Those are the tools that you have. If you don't have an ECMO machine, you don't have one.
Right, and I'm gonna just go, I'm just gonna go, out on the proverbial limb, because you know me, I'm never afraid of controversy, right? And I'm gonna be controversial now. Do you really think places should be permitted? And I think this is a public issue, but this is a professional format, so probably not much of the public actually watching this. But you know how pharmaceutical companies or even hospitals now advertise their capabilities and all of that kind of thing. Do you not think it should be an absolute standard of care? Because Impella cannot help you in a lot of circumstances. ECMO is the one thing, maybe a little more invasive than an Impella is, but if you have to have one or the other, ECMO, I think, is the most comprehensive tool that can do the most things. Do you not think it should be a standard of care that if you do heart surgery, you should have a dedicated standalone ECMO circuit available and ready for any patient that may have postcardiotomy syndrome and cannot wean from pump, and a competent staff who is trained on and does routine competencies to make sure that they maintain their ability to operate that device? Yes or no?
Yes, but I know it's not feasible in all situations. For the most part, as professionals, we can ask for things and we can do these things, but most of the time it's not up to us.
But if it's a standard of care, the hospital will be compelled.
Well, yes. I'll take that one further off topic a bit, but along the same lines. I don't understand how hospitals can have a cardiac cath lab and not have any heart surgery.
A standalone heart, yeah,
standalone. It happens, and now.
And then they perf a coronary, and then you're rushing them to the hospital in an ambulance, and they get to the hospital now completely decompensated, and we have to go operate on them, and those are, generally speaking, unpleasant cases.
Yeah, and I know those types of standalone facilities that have a cardiac cath lab, they have a balloon pump, and now today, their Impellas are kind of everywhere, and they have those too. But those aren't always, like you said, going to fix whatever it is that could go wrong.
No, and I can tell you this much: it's a hell of a lot harder to put an Impella in place and keep it in place than it is to get somebody on VA ECMO. I guarantee you that's 100% correct. There's no question in my mind.
But then, we get into
They talk about it like it's just running a little wire up, and it always looks beautiful in the video. Let me tell you, that Impella has it's a good device. It is a good device. Good device that is overmarketed and overused. But it's a good device when used appropriately.
Well, like anything else that catches on and people find, maybe a lot of people find, simple to use, it becomes the fix-all for everything, and there's nothing that is applicable to all situations.
In my 2 minutes I have left, then can I good morning to you too. Your friend Karen saying hello.
Hello.
Pertus.
Hello, Karen. Okay, so was that a good enough answer?
I think it's a great answer. It's a great answer.
We have to use the tools that we have. I think this article was great about talking about some of the, the techniques and things you need to try to do to avoid ECMO, because of course we want to avoid it when we can, but you definitely want to avoid it if you don't have ECMO capabilities.
Well, I don't think you should be doing heart surgery without it.
Yeah.
I don't think it should be permitted, frankly. I don't think it's. I think it's wrong. I think it's wrong. Who I think it's wrong for isn't me.
It's for the patient.
Yes.
Absolutely.
Because they don't know that.
Yeah, they're not going in to ask.
It's the chip shots that are always the problem. It's not the ones we knew up front. It's like I said at the very beginning of this conversation. Oh, this patient.
So you're saying that like patient selection isn't always going to do it for you?
No.
Right.
No, I've seen single vessel coronaries go down.
Yeah.
I've seen, and have to be on ECMO. I've seen double coronaries do it. I've seen the simplest aortic valve, just for whatever reason. You know, sometimes it's inexplicable. You just don't really understand what the heck just happened here. And we're putting them on VA ECMO. You don't have that capability, and you just put a mechanical valve in. Guess what? Now you're not going to put an Impella in. You're going to go change it for a tissue valve, and then do your Impella. So no, I think that if you have to have one device, if you can only have one, I think optimally both.
Yeah.
But if you, oh, well, that's my last question. So if you can only have one
between
one device, you can have one device. You can have an
Any
Impella.
device.
You can have an ECMO. You can have an
Balloon?
old style tandem. No,
Oh.
balloon pump standard.
Okay.
An old style tandem transeptal left atrial vent
Yeah.
for decompressing the left side. If you can only have one of those three items, which one would you want?
ECMO, because
Okay.
it can do it all.
Everything. Exactly. That's what I love about
Well,
it.
even, you know, previous institution, we had ECMO, but we didn't have, we had Impellas eventually, but at one point we didn't have VADs because you can put them on ECMO, you know, and then, you know, we were able to transfer to other facilities, but because ECMO would take care of it all.
Well, there's no question in my mind. For left ventricular failure, for postcardiotomy, even biventricular, for postcardiotomy syndrome, failure to wean from bypass, central cannulation, and an LV vent is, if you're putting it in, and you got to be in the LV, right superior pulmonary vein to left ventricle. Drop in your typical vent to keep that LV decompressed completely. I think you're going to have the best of all outcomes. And you can still approximate the skin.
Sure.
So you just don't pull the sternum closed. So, you know, you can still do that. Or you can leave it open, and you can use a suction system for dealing with blood loss. Use the cell saver in the ICU if you are grossly coagulopathic to manage that. I think if you have, you know, untoward bleeding, I think you need to go back to the operating room, open it back up again, find what's leaking. It's going to be a purse string on a cannula. It's going to be something. I mean, it's almost, you know, I've seen coagulopathy before, and I've also seen coagulopathy complicated by surgical bleeding.
Yeah.
Take the time to fix all of that. It's, you know, look, I mean, everybody's exhausted by the time you get to this point.
Yeah.
Leave them on pump. You're already, you know where you are. Leave them on full bypass. You know, you keep the heart quiet, keep it empty. Turn all the crazy drips off, because a lot of times when you're trying to come off, they're given this, they're given that, they're given epi, they got
You don't
this and
know.
that. Turn it all off. Let the patient clear out. Let the surgeon leave. Let anesthesia leave. Let, you know, get some relief for the perfusionist. Take a break from the situation. Just leave them laying. Just leave them there. Then come back and start reassessing the situation. Put a little of this on. Put a little of that on. Not the boluses like we've seen multiple times, because usually it just turns into, you know, it's like we didn't expect this to happen. We're off pump, and they quickly decompensate, and then you've got all these resuscitative measures going on. And so you don't have an idea what their SVR is anymore. You don't have an idea of what your flow, you know, your perfusion really is. Get everything stable, and then start fresh slowly. And you probably come off bypass more often than not, I think, if you just do it that way. But if you can't, then at least you're getting a patient transition to ECMO in the best possible condition.
Right, in the most stable manner you can.
Absolutely. I think that's so important. But I know, man, everybody's exhausted, and it's usually always in the middle of the night.
Yeah.
And there's nobody around. But you know what? Those are the times when you just got to rally people up. And come on, let's get through this, you know. And you do it more for the, now, if the patient's 89 years old and you're doing that, I would criticize that too. I think you have to be somewhat reasonable with your patient selection. I think you have to recognize what is the opportunity here for a meaningful existence. But
Not a
you know,
90-year-old with a arch replacement and
yeah, or anything. Somebody who's 70 years old and chronic renal failure, on dialysis, has had a stroke, has basically no life as it is. Look, these are very difficult ethical considerations, and but is this really what this patient would want, and what's their life going to be like?
well, sometimes
I can only
it's not
talk
even
for
the
myself.
patient.
I'd rather just, it's the family. I know.
It's the family. I mean,
know.
I say 90-year-old arch replacement because I've had that in a 10-hour pump run, and so we just took them in to do that, and of course they didn't come off bypass.
Was it an arch or ascending?
No, it was an ascending partial arch, aortic valve, and then dissection, and it was all.
So
the
they
things.
did the island. They took the arch vessels off, and then put their graft up, connected it to the aorta, and then put the island on the graft itself. Yeah, I've seen that a few times. Okay. Well, I think we've gone 5 minutes over. I want to thank everyone for being just excellent. This was a great program today. I loved the discussion.
Yeah, it was good.
A little controversial at times, but that's Tammy. We accept that from her, and we will move forward with the 14th. I don't think you're going to be here though, right?
No.
You're not going to be here, but the 14th is going to be fun.
I got to make room for all the amazing people that are going to be here.
We're going to have Devinder Bhatia here, and we are going to, I'm going to give a lecture on alcohol as a medicine. His is going to be more about wine specifically. And then we're going to do, and I'll be sending an email out to everyone, anybody that registers, whether you register or not, for credit doesn't make any difference to me. But we're going to, Dr. Bhatia, who fancies himself as, he was on Wine Magazine. I mean, he's this guy, this guy's big time, okay? We're going to test his ability, but he's going to teach us first how to judge wine, and this will be a red and a white. We'll give you we'll give you the wines you need to buy.
And all of that.
And so forth, everything you're going to need to have. And then he's going to teach us how you properly taste wine and what that experience is. We're also going to have another wine connoisseur here, and we're going to have a sommelier. So that should be very interesting.
See, there's no room for me.
No, there's plenty of room for you. There's always room for you. Okay, Tammy, seriously. But it's going to be a very interesting show. Now, we're also going to do, before that, I'm going to do a lecture on perfusion devices for our email request. And we'll get that done first, and then we'll do the alcohol, and then we'll do the wine, and then we'll do the wine tasting. And we're going to test Dr. Bhatia's ability, the great Devinder Bhatia, MD extraordinaire, wine connoisseur.
Man extraordinaire.
Yes, man of the town, okay. His ability to tell us we're going to have a bottle of somewhat expensive wine, modest priced wine, and super cheap wine. And then we're going to have some secret wine, which is a category of all its own. And we're going to see if he can pick which one is which. And so the challenge is on to Dr. Bhatia. And y'all want to join, y'all want to watch this. This is going to be a lot of fun. Thank you all so much. Good, happy week to y'all. Monday morning, thanks for joining us. And we'll see you next time on the 14th. Tammy, once again, great show. Thank you so much.
Thanks, everyone.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.